So for mine, it's going to be spinal robotics in simple and complex MIS cases. Now, for those of you who have seen some of my talks before, this is a slide that I use often. And again, what you see here are robotic arms, right? So these are CNC machines that build our phones and cars and spaceships and textiles. And this has been going on for quite a long time in industry. And these CNC machines, as you can see, are very accurate, precise, and reliable. And now we finally have an opportunity to bring this to the operating room. And for this, it's just a natural evolution of a tool, right? So when you think of putting a screw in drywall, you have your manual screwdriver, then you have your power drill, and then eventually you have something that's partially automated or fully automated to put that screw in drywall. Now, for all of these machines, which are CNC machines, they need an input, right? So the input is what you tell the machine on what to do, and the machine executes that. And so for robotics platforms, they all require a plan, right? So that's oftentimes where you'll hear about the robotic plan. And this is the input to allow you to carry out, right, where you want the robot to go and how you want the robot to guide you. And so with this plan, then, it is essentially what we are already doing in terms of how we plan our cases and where we want to put our screws or cages, except now you can put it all in one place to help you design your construct and execute your surgical goals. So of course, with the robotic arm, the idea is that once you have your plan, the robotic arm goes into position, becomes rigid, you put your drill, tap, screw, you release your screw, send the arm to the next level, and then again, you put your drill, tap, and screw, and then you release it, right? And it's meant to be that boring, for lack of a way to say it, because you're trying to partially automate a part of the case that is going to be less important than all of your other surgical goals. So in terms of this talk, it was meant to be how to incorporate robotics into simple cases versus complex cases. I think someone argued that there may be no simple cases in the spine, especially when you're trying to prevent adjacent segment or trying to prevent PJK. But the way I've distributed it, I think, is going to be your MIS Degen and then your MIS deformity. And I know throughout the rest of the day, there's going to be great talks specifically focusing on these topics. But hopefully this will be a bit of a preview as to what the rest of the speakers will be talking about. So in terms of simple cases, for each case, I'm going to be including tips about patient selection and kind of the technical things on either using the robot. What I term usual robotic care is just sort of the robotic technique. So similar to navigation, the robot will require the surgeon to do things to try and reduce the amount of error. So things like don't bump or lean on the patient after registration. I start all my instruments off the bone, and I found that this minimizes skive. So when I put down the drill, tap, or screw, I'm starting it down the tissue protector so that you don't slam it into the bone and introduce skive. And then, of course, light touch surgery. So try not to introduce air into a system that is meant to be as accurate as possible. So the first case, there's going to be 6 cases total, which I figure about 2 minutes per case. And then we can talk for a discussion afterwards. An MIS TLIF, right? So 1 or 2 level TLIF. This is a case that's very familiar for all surgeons. And incorporating robotics into your MIS TLIF is very straightforward, right? So here's an example of putting a screw using the robotic arm down in this case, it's a mini open incision using a quadrant, but it's really no different than what you're already doing. So if you're doing your MIS TLIF with either fluoro or navigation, incorporating the robotic system really doesn't change your workflow. In this particular case, it really is just another way of putting down a screw. And you can see the straightforwardness of putting down that screw, right? So this is for a 1 level TLIF. If you're doing a 2 level TLIF, right, same thing. So here again is a video of putting down those 3 screws. And again, as you'll see here, this is the top screw. I put screws proximal to distal just because you're going from farther away from the arm to the closest distance to the arm, so the potentially least accurate. And in this way, it's just a paraspinal incision. And you can see how straightforward it is, right? So even if you're very fast and proficient with navigation, this is showing the drill, this is showing the tap, and then of course, lastly is the screw being placed. And it's meant to be this straightforward, right? As nice as it's been to put in screws using navigation, which I did earlier prior to the robot, the addition of the arm has made that even more straightforward. And then, of course, you just proceed with your MIS TLIF, and then your incision, and then, of course, your usual closure. So in this particular case, the patient selection, it's any patient you would do an MIS TLIF on. And then technical, there's really no difference, right? Just your usual robotic care. I personally do screws first and then cages, but the reverse also works well if that's your workflow. Now, the next is single position, right? So here we have a 4-5 single position OLIF, and this is showing a 4-5 spondy. And this is following, of course, Rick Hines' great talk on the single position surgeon. But if you don't have the luxury of having his, really fantastic bed, then single position for 4-5, using robotic arm is very doable, and it's very nice in a lot of ways. Like I mentioned, the robotic arm requires a plan. So here's your plan, right? So here are the screws already being planned. The patient's position in the lateral position, right? Positioned all the way close to the edge of the bed in preparation for screws being placed in the lateral position. And you can see here that the benefit of the robotic system is because all those screws are planned. And so instead of putting it under navigation or even fluoroscopy, it makes this part of the case much more straightforward. Once the robot is registered, I don't need to shoot any more fluoro, right? So the arm here is being sent to the L4-5 level, similar to a navigated case. And so once I know that trajectory for 4-5, then the arm is then sent back to my assistant, and then screws are placed at the same time. And you can see here that workflow where while I'm exposing for 4-5, my assistant is placing screws in the lateral position. And so it's simultaneous, or as near simultaneous as you can get if you have the luxury of having a second surgeon or an assist. You can see here the benefits of an anti-psoas approach. So the X is 4-5. Doesn't matter where the iliac crust is, right? So I'm going in front of the iliac crust. And then, of course, you have the robotic system telling you that I'm at the correct disc space. So I don't need to shoot another fluoro shot for this part of the surgery. The retractors go in. And then here is the robotic plan, and then the intraoperative fluoroscopy. So again, for a single position lateral decubitus case, incorporating the robot is very, very beneficial, because now you have a rigid arm that allows you to place your screws in lateral position. Now, I'm not going to lie, and I know Dr. Luis Pimenta is going to be talking about prone lateral. And, Juan always says that surgeons naturally want to place screws in the prone position. I think that's just a natural way to do it. But again, if you choose to put it in lateral, the robotic arm is just very, very useful for that. So for patient selection, any patient you would do an anti-psoas approach on. And then technically, you really want the patient to be taped down very well to minimize movement for your lateral position screws. You want to put in the right-sided screws first. That way all the blood drips down, doesn't get in your way for your left side screws. And then the anterior surgeon can expose simultaneously. I've tried to coin the SRSPS, which is simultaneous robotic single position surgery, to much failure. But in case you ever see SRSPS in the literature, that's essentially what it means, where you're doing simultaneously because the anterior surgeon can't expose at the same time. Now, the last Degen case is 5-1, right? So as Dr. Hines has said, and there's another great talk later today, 5-1 is still really the only case where you can do single position with a large cage. So here you have 5-1 spondylosis, patient coming in with foot drop. This is again, the robotic plan showing the screws. So the screws are already planned. In addition to that, I can plan where the posterior and anterior disc space is. So as you learn the OLIF or lateral ALIF technique, you mark the disc space so that you find the sacral slope. You can see this gentleman, right? So high BMI, which is more ideal for a lateral ALIF. I think all my vascular surgeons, hate doing supine ALIFs in people who are over a certain BMI, just because all of that fat gets in the way. But for a lateral ALIF or 5-1 OLIF, all of that falls out of the way. Patient's position again, right to the edge of the bed. And here you can again see once the robot is registered, I'm sending the arm to the disk space. And specifically, I'm sending it to the anterior disk. And then I mark that, and I send it to the posterior disc, and then I mark that. So now I have my sacral slope. The arm is then sent back to the posterior surgeon. So while my assist is putting in those 4 screws, I can expose anteriorly to the 5-1 disc. And here is what that exposure looks like. And again, for that exposure, a great, powerful way to put in a large ALIF cage. You see your psoas here. You know that medial to the psoas is the left common iliac artery. Underneath that is the left common iliac vein. Here is the discectomy, right? So you get a full discectomy from top to bottom, which is side to side, ipsilateral to contralateral. And then you have a large ALIF cage being placed in. And you can see here, just like a supine ALIF, you get a really powerful correction and distraction of the 5-1 level, right? So you have pre-op and post-op. So again, a good correction at that level in the lateral position with screws placed in single position. So for patient selection, it's again, any patient you would do an MIS lateral ALIF on, right? So you would just have to check your vascular anatomy. Vascular to expose, if you're unfamiliar with the exposure, of course. And so your vascular surgeons will just have to be on board in performing this type of surgery. And then technically, it's going to be the same as your lateral positioned 4-5 or higher lateral cages, where the patient needs to be taped down very well to minimize any movement for the lateral position screws. Again, put your right-sided screws first, and your anterior surgeon, whether it's you or your vascular surgeon, can expose. You just have to be careful not to move the patient during the screw placement as you're exposing, but to save time, that can still occur. So those are my 3 quote unquote simple cases. I think moving on to incorporate robotics into complex cases, I think this is where you start to expand and see more of the benefits of the incorporation of robotics. So the first is minimally invasive deformity. And in this, I'm showing an L2 to S1 OLIF, and then a 2 to ilium, minimally invasive perc in the single position, right? So you have someone like this who's got a mismatch of 35, a pelvic tilt of 48 degrees. He's a tall guy at 6'4". He was in the Navy, used to move around ordnance, right? So moving around missiles and bombs, so huge guy. That's probably why he's able to retrovert his pelvis so much because of his imbalance. So in looking at this gentleman, right, as a virgin case, we figured, is there a way to offer him a minimally invasive option? If we put in cages at those levels from 2 to 1, will we give him back enough to balance him? And this is what the patient-specific rods and predictive analytics are meant to do, to try and see if that's enough. Now, in moving forward with that plan, again, as I've shown you earlier, the robot needs a plan. So here's the L2 to S2 plan for the screws, and then the placement of those cages simulating what that correction would be. And again, you have a very good way to line up the screws from L2 down to S2 AI. And the purpose essentially in putting S2 AI screws, I typically routinely will put iliac fixation if I'm going up to 2, especially since he's so big and heavy. It's just a weight off of my mind that even though I'm putting in a 5-1 cage, that I won't halo out my S1 screws and protect them with iliac fixation. And really now, one of the biggest reasons is that I can, right? We can do it in single position. So here you have the incision for L2-3 and L3-4, and then you have here the incision for 4-5 and 5-1. So with this video, this is the 5-1 cage going in first. And again, you really see the benefits of lateral decubitus positioning. So although you give up a lot of things, as Dr. Hines has talked about, the ability to put in cages from 5-1 all the way up is a really powerful way to keep lateral decubitus positioning still in your technical armamentarium. So that was the 4-5 cage. It was oblique. And here you have the 2-3 or 3-4 cage going in, which is more of a direct approach going down into that space. This is the S2 screw going in, right? So you have the L2 to S1 screws, S2 AI screw going in, and this is what it looks like. So you have L2 screws at the top, you have the S1 screws at the bottom in these paraspinal incisions, and then you have your iliac fixation of S2 AI. And here's a video of what that looks like, right? So the robot comes into position, and then of course you put in all your usual tools. Here's your robot knife, which is a 22 blade. You have your navigated dilator, which is essentially a cannula and tissue protector. You have a long drill. And again, I'm sitting down, and I'm not going to lie, it's a bit awkward, right? Putting the instruments down, going from from floor to ceiling. But otherwise, the video is quite boring, right? I mean, all you're seeing are drills, taps, and screws, and it's meant to be boring, right? So as opposed to doing this with fluoroscopy or doing this with navigation, where you're looking back and forth, and it can be a terror, right? To slip off of the bone and be off of your trajectory. The robot arm keeps you in place so that you can actually place these iliac fixation points while in lateral. So again, you have this pre-op scan of 22 degrees of lordosis tilting at 48 degrees. And already in the hospital, he's releasing his compensatory mechanisms, right? So I gave him back the lordosis that I wanted. He's got a pelvic tilt down to 16 degrees. And again, the power of some of these predictive analytics is you see here in the middle screen, this was the plan. And the plan doesn't just give him lordosis to match his PI, but the plan is trying to predict how much he'll actually release his pelvic tilt. And what's really nice here is you can actually see the plan is helping to predict that he's actually going to unflex his knees, right? Which I think is so interesting and powerful, and something that as we move forward with technology and machine learning and the use of predictive analytics and AI will only help us be better in terms of the plans that we use, right, to help these patients. So for patient selection, the PI-LO mismatch has to be low enough to be corrected with inner body cages only, right? And as spoken in the earlier talk, you have to rely on indirect decompression if the screws are placed in lateral. So you've already decided up front that, especially in the lateral position, you can't be doing any osteotomies, decompressions. It's just going to be too hard with all those screws. And then it just has to be an appropriate lateral ALIF candidate and appropriate, anti-psoas candidate too. From a technical standpoint, I put all my cages in first with fluoroscopy. The right-sided screws go in first as well, just like all screws in lateral position. I put in L2 to S1, and then the iliac screws go in last, just because there's so much bony attachment that it really moves the patient to get in those screws. You have to check the robotics software for potential tower collisions, right? Just because you're putting in a lot of screws, PERC or transfascial. And then bailouts, right? I mean, when you're putting in something like this, either for the first time or the third time, you always have to wonder what you do if you just can't get in that iliac screw. Bill Taylor here at UCSD is a fantastic mentor and obviously another leader and legend in the field. And he always says that it's one of the hardest things for a surgeon to do is to change the plan once you're in the operating room, right? Once you're in the operating room, you have a plan, you want to just run through it. One of the hardest things to do is to change that plan if things aren't going your way. So if you can't get in that screw, bailouts are to just leave in one screw, which is fine, right? People have put in single iliac fixation points, put in no iliac fixation, because arguably you have S1 in a large ALIF cage, or just flip prone, right? If none of your lateral screws are going in well, you're cursing the robot, you're cursing the decision to do something in lateral. Again, you can always just flip prone, do your nav, and still accomplish your surgical goals, right? Just have to be okay mentally with changing that plan. Now, the last two cases, complex cases, are going to be minimally invasive deformity cases, right? Again, another area where robotics really shines. And in this particular case, it's going to be a T12 to L4 OLIF with a T9 to ilium, minimally invasive, multi-rod posterior spinal fixation infusion. So I have a gentleman coming in, Degen Scoli, with sagittal imbalance. He's 75, turning 76, right? So high functioning guy. And again, his charge to me was that he wanted to be better because he was still, golfing and sailing on his boat, but to not kill him, right? And of course, we all know the morbidities that can be associated with open surgery. So, I'm thinking to myself, is there a way to give him back his lordosis using either minimally invasive or at least mini open techniques? The robotic software is nice because you can help to plan in an ideal world what some of your cages or osteotomies will do, right? So here I'm putting in 4 cages and I'm putting in just a little bit more of a PCO in the back. In an ideal world, if I get him 35 degrees across this region, will this balance him? And if you look at the bottom, his mismatch is 25. It gets him back to -9. This would be a successful plan if I'm able to accomplish that. Now you can see this plan. We're talking about putting in screws from T9 down to S2 and putting in multiple rods. So I'm not I'm not a superhero like Neil Anand. I know is in the audience. I know he's been doing this for a decade. And unfortunately, I don't have his X-ray eyes to be able to line up screws with either X-ray or fluoroscopy. So being able to do this on the robotic system now makes that feasible because I can design these screws and the rod, as you can see, is planar, right? So it's a straight rod going down from T9 down to S2. And with this, the hardest part mostly is just getting the correction. So I put in my cages from T12 down to L4. Here are the screws going in trans fashion, right? So I've done this both ways. I've done the stab incisions. I've done a single skin incision. This is an example of a single skin incision. And you can really see how bloodless it is. And for someone who's 75 turning 76, I just don't want to have the stress of blood loss and fluid shifts and checking the lactic acid and the base deficit and making sure I have a good anesthesiologist so that he doesn't get behind. These screws go in and it's a nice, comfortable time in the operating room where I know he's not going to die. Next, you can see here just this forest of towers, which is already daunting. The fact that the screws are already planned, though, just makes this the result of it, right? It's not something to be scared of because I already know where the screws are going because I planned them. The next up is this is just a demonstration to show that with the robotic system, it is accurate, right? I mean, is it more accurate than nav? Is it the most accurate and perfect thing? It's not perfect. It's as accurate or a little bit more accurate than nav. There's going to be potential for error. Nevertheless, when you talk about a complex case like this, it is very, very good. And you can see here, even in the registration, the robotic system has detected that those cages have given my patient lordosis. Each one of those bones has been separated because it's detected that those bones have moved in 3-dimensional space, and it is still going to place those screws into those bones in that 3-dimensional space. As with my plan, I wanted to do a mini open. So I just opened up from T12 down to L4 out to the edges of the pars, right? And just to leading up to the bone. So as opposed to an open case where I'm exposing TP to TP, I'm just exposing enough for my osteotomies to get a little bit more compression at that level. And then this is my final construct, right? So passing down multiple rods with a variety of screws. And again, when you look at the CT scan, I have your traditional transpedicular screws, in, out, in, juxtapedicular screws, cortical screws, iliac screws, S2 screws, essentially any screw in bone that makes this line up and gets me good fixation. And it's all very accurate, right? So as long as you have good technique, then the system is very accurate. You can see my pre-op prediction. In an ideal world, if I can get 35 degrees across that region, will it match him? And you can see here, that result, right? So for someone like this, 75 turning 76, he went straight to tele, right? So skip the ICU, no blood loss, out of the hospital in 4 or 5 days, walking the next day, right? And the ability to design robust constructs like this now is possible, right, with the robotic system. So in terms of patient selection, I would certainly defer to the MIS DEF2 criteria that Praveen released, especially if you're starting to do this. It's a great way to categorize some of these deformity patients. There will be some who are just not good for MIS. Your MIS surgery is never going to be as good as open, but that means that for patients who are too frail or just not ideal for open correction, this is still an option for them. And again, in terms of that correction, you just have to rely on cages or a mini open posterior column osteotomy with those cages to add some more to make sure you still hit your surgical goals and your parameters. From a technical standpoint, you have to be comfortable with your lateral approach for interbodies because you rely a lot on that, whether for coronal or sagittal correction. And in this case, you have to be familiar to planning the screws yourself. Your techs are great, and all the plans earlier and all of the Degen cases, your techs can plan them for you, and you can just make minor adjustments. And each region and practice is going to be different. If you're doing MIS deformity for screws, you really just have to be familiar to plan it yourself because it's much more complex, especially if you're trying to put in multiple rods, transfascial or percutaneous. And then lastly, you just have to decide how you want to perform your facet fusion. So this is more of a minimally invasive deformity problem, but you can do a robot guidance. You can do a navigated drill, which is what I typically do after my O-arm spin. You can do it blindly, right? Just putting down a drill between your transfascial incisions and then decide on your graft, right? Put in none, put in DBM, and I know some places are using BMP. So the last case I'll do, which I'm a little bit behind on time, but this for the last deformity case, T12 to S1 OLIF and then a T9 to ilium multi-rod. So again, another deformity case. Right, you have a lady coming in, Degen scoliosis, pelvic mismatch with a pelvic tilt of almost 40 degrees. And again, her BMI is 42, right? So you're looking at someone who's not really the ideal candidate for an open correction, especially when you consider all of the wound complications for folks who are up at this BMI. But as a fairly flexible deformity, and for someone who's never had surgery, there's the possibility of putting in cages and getting that correction. So you can see here the robotic plan of going from T9 down to S2 with multiple points of iliac fixation. And with this robotic plan, I can try and simulate what that correction would be, right? So in an ideal or near ideal world, what can I get and how much can I correct with this? And again, you'll see here with the cages going in, there's nothing that's going to be more powerful than an A-lift cage at your 4.5 and 5.1 levels. And if you can do that in the lateral position through an MIS approach, then you can continue to walk up and don't have to reposition for any of your other cages. So you see here, you have your 4.5, 5.1. I put in lateral cages the rest of the way up. And this is the intra-op. And already intra-op, I've been able to correct her coronally, right? You can see here are her incisions. So to be able to put in 6 cages through an incision for someone, as you can see, as big as her, 3 inches and 2.5 inches is incredible, especially when you're talking about a minimally invasive philosophy. Because this was staged, I stood her up in between the stages. So she has a good correction of her coronal deformity. And this is a good estimation, right, of what I was sort of predicting to what I actually got. And then sagittally, right? So you can see here, I'm getting back just with the cages alone. I got about 40 degrees, right? Already hitting, very near hitting my target. And a lot of that is from my 4.5 to S1. But as you know, Neil Anand will tell you in a lot of his talks, you can get lordosis from your lateral cages as well. And you can see here a great prediction, right, of what I was going to have. The robotic plan comes in, T9 down to S2. And again, you can see how that really eases a lot of the planning by placing these screws percutaneously and putting in the idea of multiple rod fixation, especially for someone who's bigger and is going to be stressing that level. This is the intraoperative 2D film, right? So all the screws have gone in. You can see 4 rods going down to get that extra fixation. And then you can see here the passage of those rods. So there's 3 rod holders coming in here. The 2 people in the background, it's my PGY7 and my PGY2. And I kid you not, passing these rods took about 10 minutes time, right? And it's because all of the screws are already lined up. So as long as you know how to slide that rod and give it a little bit of, grease, right? It'll go from screw to screw to screw to screw, and it'll just slide all the way down. The hardest part really is just getting through the soft tissue, but finding those screws is not that hard, especially when all of the rods are lined up. Here's her post-op films, standing. So again, you have correction of her Degen scoli. Again, good apposition to my predicted plan. And then with her standing, I got position prone, right? A few more degrees, almost about 10 to correct her. And again, good apposition to what I was essentially predicting. So for someone like this, right, to be able to offer a construct that is minimally invasive, no drains, no ICU stay, no blood transfusions, is incredible. And I think the placement of a construct like this is only possible by the incorporation of robotics, right? So the title of the talk, how do you incorporate robotics into your simple and complex cases? This is a great case to demonstrate its utility. And again, with the predictive analytics and confirming that this plan is enough for her, right? You again see the relaxation of her compensatory mechanisms sagittally, which is a really powerful way that although open surgery would have given her more, I think this is enough to give her a really great outcome. So patient selection, similar to the prior case, you just have to be sure they're appropriate for a minimally invasive approach. And you just have to be comfortable with your lateral approach, planning your screws, and how you want to do your fusion. So, in conclusion, a lot of the talk about robotics is how to put in screws. Do you put in screws with nav, fluoro, freehand, you use the robot? But I think, that's just a small window into what the bigger picture is, right? And the bigger picture is that the use of these robotics platforms and predictive planning on the software is really allowing us to do our surgeries, the same surgeries we've been doing, but in a potentially different and better way, and especially for minimally invasive surgery, right? Where you don't have the luxury of seeing the open spine. Incorporating robotics into minimally invasive surgery, I think is really going to change and improve the good things that we're already doing. So a little bit over time, but thanks again for listening.
That's a great talk, Martin. I don't know if there's anyone in the audience with a question. I actually agree with you. Just for pedicle screw accuracy, that's really been what's promoted with robotics, and it's not a value add. I don't think it's any better than conventional navigation. It doesn't justify the cost. So it's really comes down to what else it offers, and the ability for predictive analytics, which is also in its infancy. I think is going to be a big plus for the robot, and as well as increasing everybody's technical skills to a certain level. It does actually ease some of the physical demands of an operation, as you mentioned. So those are two big points that I think I've personally found to be a use for the robot. Anyone with a question? Timur?
Quick one. Martin, big fan of your Instagram page. Nice presentation. I'm going to call you out on something just for the sake of discussion.
Yes, please.
In your own TLIF, you were mentioning that you go from the further levels towards the pelvis where you have the navigation array.
Yes.
The accuracy changes. But then in your lateral, you're talking about doing all the right screws first or the floor screws first, I guess top to bottom, then converting back to the top level, but on the left. Doesn't that contradict your the two statements? It
does. And I think in that case, I'm splitting the differences. I think in an ideal world, you would do L2, L3, L4, L4. But I think in that particular case, it just makes more sense to stay on that side. You'll find I probably contradict myself a lot. Don't search for me, because I'm sure I have a bunch of talks out there where I'm just saying different things and saying that the robot is terrible. But that's true. I think in the lateral position, the caveat in doing it that way just outweighs sort of the benefits of the workflow.
Yeah. Neil.
Martin, very lovely talk, very elegant cases and well done. There's a comment really. There was a big deformity case, I think, beautifully done and very elegant, like I said. I think as you get more comfortable, you might find that you do not need that PCL in the back to really be MIS. It comes just with the laterals. Trust your screws and rods to get you where you want. And I'm not sure you need those multiple rods. You'll be fine with two rods. There's so many bodies in there that I can just do not have any problem with two rods. We just published our hardware failure rate. It's 2.2% over 13 years with two titanium rods. So pretty comfortable today that I think we need to move away from the open philosophy, right? It all comes from that open surgery.
It
where you
does.
need multiple rods. We're not doing that. So there is definitely a paradigm shift here, and you might find again, just look at it, you start getting comfortable with 2 rods. Everything else was perfect. Really well done.
No,
Yeah,
I
no.
really appreciate it too, and I will admit it's a bias, of course, from spending an entire year with Larry, Lanky, and Ron, and just seeing the multiple rods, and I think that's a carryover. But I do think that especially when you're not disrupting the tissue and all of that is intact, the failure rates should be, and as you're saying, are lower.
Great, Martin. I think we could extend this discussion ad nauseum, actually. Great talk. But we need to move on. We're a little bit behind. So, I don't need